with nonprofit collaborators, including Climate Central and AmeriCares. We're living in a warming world. It has gotten hotter. We are seeing longer heat wave seasons. We are seeing more intense heat waves when they occur. I don't think I need to belabor this point, given what has been going on in the media this summer around heat. I think this is fairly obvious to everyone, but I do like to include these graphs because there's no modeling, there's no computer projection here. This is simply what happens when you add up thermometer readings from around the country over the last few decades. So we are dealing with an escalating hazard. This has particular impacts for some of the populations that this group is interested in, particularly those who are dealing with substance use disorder, which of course intersects with unhoused populations and may include people who are less able to adapt to changing environmental conditions. The way that I think about heat from a sort of mechanistic and social standpoint as a physician is that part of the story here is high temperature, right? And that is where the climate change forcing piece of this matters, because temperatures are going up and the extreme events, those really, really hot days or periods of hot weather that can have big health impacts, those are getting more frequent and more intense as a result of climate change. But I think it's really important to emphasize that that by itself is insufficient to make this a really big problem. We also have to think about the social context and the geographic and housing factors that play into whether people are exposed to that heat. Because if it's a hot day and I'm inside in air conditioning with a power grid that is functioning, I'm going to be fine. And where we run into big health problems is when we are dealing with people who either don't have access to safe housing and cool spaces or have to be out in the heat because of their job. So first responders, police officers, outdoor workers, highway crews, construction workers. There are a whole lot of people in the Commonwealth that cannot escape the heat by nature of their job. And so those factors combined, the high heat and the exposure to that heat because of social, work, or housing factors, that produces something that is dangerous. And then I think it's also worth emphasizing that this ties into our energy systems. As it gets hot, people crank up their AC, and that in turn increases demand on the electrical grid and risk of power outages. And this has been an issue, particularly in California in recent decades. They've had rolling blackouts during periods of hot weather. So something we need to stay tuned to. As we look ahead to the future, this is where you're dealing with computer models. We don't know exactly what's going to happen. I think there is broad agreement around the fact that it will be worse than it is right now. What exactly will that number look like depends what we do in terms of decarbonization and depends a little bit on how some of these feedback loops in the science play out. So projections, bottom line, suggest we are dealing with an increasing problem that we need to continue to prepare for. Which brings us to what this means for people's health. I am really concerned about this as a physician. I'm looking ahead to decades in practice in emergency medicine dealing with increasing impacts on my patients from hot weather. Some of that will be things like heat stroke, which is a extremely time-sensitive medical emergency. Some of that will also be things like the woman I took care of a few years ago who had an air conditioning unit in her triple-decker apartment that broke. And she ordered a new one, but she didn't have the upper body strength to install it in her window by herself, didn't have someone to help her, and wound up running a fan during a heat wave, became dehydrated, and came to me and had to be hospitalized for a few days after that. So there are, again, important intersections between our sort of social and housing fabric and these hazards. And it doesn't entirely show up in the statistics on heat-related illness. So that's just something to keep in mind in the background. Very quickly, this is a long list of the things I worry about as a doctor and an emergency physician when we are dealing with heat waves. And this includes the obvious stuff, the heat stroke, the heat exhaustion, but also things like heat cramps, things like people getting lightheaded at the company barbecue, people thinking less clearly. There's a whole body of research showing that as the temperature goes up, people have problems rapidly completing cognitively complex tasks. Senior citizens may not think quite as clearly. People with early dementia who are still living alone in the community may not be thinking clearly enough to know that they should turn on their air conditioning or change into lighter weight layers that make it easier for their body to cool down. So lots of concerns there about all the myriad of ways that heat can affect the human body. And finally, all of this turns into impacts on healthcare, We see increases in hospitalizations. We see increases in the number of people coming to emergency departments during hot conditions. And we have to be prepared for that, because if you happen to have your stroke or heart attack on a really hot day, that might mean it's harder for you to access care. And so this does affect everyone, even those who are not directly exposed to the heat. I also want to emphasize sort of the intersections between heat and substance use disorder. This is an opioid task force, and I think we should be very explicit about thinking about how the population of interest to this group is in many ways also the population of interest for those of us who are working on heat. From a social standpoint, I think the housing issue and the access to cool spaces issue is a really important one. It's also worth emphasizing like really basic stuff, like do people have sun hats if they are unhoused and living with substance use disorder? Usually not, in terms of the people I'm seeing brought into my emergency department. Do people have transportation if they're trying to get to a shelter or get to a food distribution point or get to a needle exchanger, whatever they need to do? Do they have a way to get there that doesn't involve walking in 95-degree heat for long distances? Because that, again, increases metabolic activity, makes it harder to cool the body, and puts them at risk of heat stroke. Finally, access to clean drinking water is also a surprisingly big issue for a lot of people. And then the substances themselves also substantially contribute to risk. And there's two broad buckets where I've seen this play out. The first is that opioids, alcohol, benzodiazepines, and other drugs in the sort of downers category can make people less responsive to environmental hazards that are going on around them. And so if you use and then are out in the environment as it becomes hotter and hotter during the course of the afternoon, you may not be taking protective action. And I will also add that as people become used to see people who have used, their alertness to the fact that someone is acting oddly may be a little bit lower, because that's a common feature. And when I think about heat stroke, the definition of heat stroke is an elevated core body temperature plus altered mental status. And so I am concerned anytime I see somebody with confusion, but if that's a common thing in a certain part of a neighborhood or city, that may change people's like sensitivity to activating 911 to get somebody emergency care for what actually might be heat-related illness. And I have taken care of people who were not involved in any form of drug use, but the chief complaint when the 911 was called was, I think this guy did drugs and has now collapsed. And the actual answer was heat stroke, their core body temperature is 108 Fahrenheit. And so we have a real like education issue around this issue to deal with as well. The other piece of the substance use disorder thing that we need to think about is stimulants, which I think, as mentioned at the beginning of this call, is a big issue in this part of the world. And when you take cocaine or meth or other stimulants, it increases metabolic activity. And so the body generates more heat, and that increases the risk of heat stroke. And there's increasing data coming out, particularly from the Southwest United States, around things like meth and heat stroke risk. So again, something we need to be paying attention to. Moving quickly just to a couple of other thoughts on what we are trying to do about some of these heat issues. We are trying to develop interventions that can run through healthcare organizations with a focus on the patient. And I want to emphasize that this should not take the focus away from all of the other places we can be doing solutions. We need decarbonization solutions. We need policy solutions at state and municipal levels. This is indeed intended to complement those efforts and make sure that individuals have access to the educational resources they need to stay safe as part of a larger comprehensive heat adaptation strategy for a society. The idea here is to work with clinics that are serving patient populations that are at disproportionate risk. And there's a whole body of epidemiological evidence around who that is. It includes many of the populations of interest to this group. What we've developed is a couple of different things. The first part is toolkits. And so these are educational resources for providers, patients, and administrators. And I think we may have a colleague from Cambridge Health Alliance who is able to join us in a few minutes, who is using these resources and receiving some of the heat alerts that we're talking about, and can speak to how she's working with patients around counseling on these issues. The second is these heat alerts. And so this is a pilot program we're running this summer with Climate Central, which is providing information to clinicians saying, hey, it's going to be dangerously hot where you are in the next couple of days. Here's a link to some resources you might use with your patients. And I think it's worth emphasizing here that while we are in the Northeast, it has not been as hot here as it is in Texas or Arizona. It doesn't need to get us hot for us to start seeing mortality impacts. So the picture on the right here is a heat index range for getting peak hospitalizations. There are similar maps that look at something called a minimum mortality temperature, which is sort of the optimum safe temperature. And the further north you go, the less well adapted to heat we are as individuals and as a society because of things like architecture and urban design. And so it doesn't have to get as hot in New England to produce an increase in mortality as it does in Texas. So something to keep in mind as you read the news. Here's where we're working with clinics. The red arrows are where we are piloting these heat alerts that clinicians can receive, and the yellow arrows are clinics we're working with to pilot these toolkits of educational resources. So pretty broad coverage, including with Cambridge Health Alliance here in Eastern Massachusetts. And this is a quick frame of sort of the project, which is very much in progress. We are at the stage of having developed these interventions, version 1.0, and we are now doing qualitative research over this heat wave season to understand how these interventions are going when they're implemented by a select group of clinicians and clinics. And so we will be doing semi-structured interviews this fall with the users of these to understand, did this work? Was it effective? How can we improve it? And what additional resources might be useful to them in dealing with this issue? And I want to sort of segue from that into thinking about where the intervention points might be, both in terms of the projects we're doing and also more broadly in a society. This equation here, for any of you that have done emergency management work, is probably pretty familiar in terms of how you think about risk as a function of the hazards, things like heat, the exposure to those hazards, whether people are vulnerable to them, and whether people have the capacity to adapt to them. And so a lot of what we are doing with these projects is looking at populations or sites that are vulnerable and are exposed to a hazard and trying to work on capacity or resilience to those hazards. So taking steps that can help keep people safe when they're exposed. But I think it's worth emphasizing that this has to go hand in hand with other projects. You know, for example, work that Boston Medical Center and the BU School of Public Health have been doing around like cool neighborhoods is really exciting. And that I think we need all of these projects going on simultaneously so that people are exposed to less heat and have been able to take steps to keep safe when it does occur. This is a quick look inside the toolkit. So we have also a Spanish language version of all of this at this point. But there's a lot of different resources for different patient subpopulations, including people who are pregnant, people who are living with mental health issues, which again coexists with some of the substance use issues that this group is probably interested in. And a lot of the medications that people take for mental health issues, including antipsychotic neuroleptic medications, those actually affect your body's ability to thermoregulate and can have implications for your susceptibility to heat. So really complicated issue. And we provide some sort of patient-oriented and provider-oriented tips and checklists and action plans for what to do when the weather gets hot. Things like keeping track of how your urine looks. Are you hydrated? And recognizing when it's a medical emergency and it's time to call 911 or make your way to the hospital. So this is the old version of the email language of our heat alert text. There's an updated version that has been going out as well. And I'm going to sort of close by just emphasizing that this is a big picture issue. We need to be mitigating climate change through a lot of the work, for example, the offshore wind that will be hopefully going in Massachusetts in the near future. But we also need to adapt, and we have to be doing both of these things at once, and doing one does not detract from the other. They're both really important at this point. And for the populations at risk, the adaptation really does need to be implemented in a way that makes sense for those populations and is responsive to their specific needs and addresses some of the health inequities that climate change is exacerbating. So what those solutions can look like is enormously variable. I think there is something here for everyone and every organization in different ways. And in the interest of time, I will just add, we have links to both of these projects that you can read more about. I will share the slides after this if they need to be emailed out so people have access to these links. And I will close there and would love to hear sort of how you're thinking about heat as it intersects with the work of this group, answer any questions that anyone has, and then if Deirdre has been able to join, I think we might have a nurse practitioner from Cambridge Health Plans on the line here as well who can speak about this in practice.
Thank you, doctor. That was really fascinating, and obviously raises what we see all the time, which is the impact that heat has on folks' interaction with the criminal system as well. Again, when you talked about people not making good enough decisions or doing that kind of thing, we see that all the time in things that shouldn't happen and probably wouldn't happen if it wasn't 90 degrees. People have, there's so much to talk about there, but people have questions or comments for Dr. Dresser. If you want to raise your hand or call out, we've got so many people here, it's a little hard to keep track across the screens. Anybody, comments, thoughts? Carol.
Hi, thank you so much. It was fascinating. And I work for the town of Needham in the public health division, and I work on a substance use prevention grant that's the towns of Dedham, Walpole, Westwood, and Needham. But I'm really going to ask you, as far as having my Medfield Board of Health hat on. I haven't heard your presentation at local public health. We're all impacted. And do you ever give this talk to say, you know, we have a webinar twice a month, Office of Local and Regional Health. I'm just thinking how valuable the information is as volunteer Board of Health member, of course, as a staff person too.
Yeah, I give this talk or variations of it pretty widely, and I'm happy to join a group and provide education on this. That's a big part from my standpoint of how we need to address this issue. Is we need a common language to talk about it and sort of a common understanding of what the hazards are. And then the solutions will to some extent flow from a shared understanding of the problem.
Yep. And the toolkit is amazing. So I appreciate the resources, and as DA Ryan said, so applicable to the past few days with what our locals have dealt with. So thank you.
And we will share all of the slides when we send out the map and all the other information as well. So people will get all of that. But that toolkit is amazing. Other questions, comments? All right, Doctor, thank you. Thank you. I'm sure we will talk again. You know, one of the things we've talked to, and we have such great public health departments and police departments across our county, but one of the things is always just the impact of dehydration on people who are using substances, and the appeals I've sent out so many times this season of please just put water out on the street, do what you can to get water out to people. It is even in those simple things that we are seeing these big changes. I used to do that maybe once a year. I've probably done it 10 times this year.
Yeah, that's really good to hear. And thank you all for having me. I will add on that note, I was traveling in Italy and was really struck by the fact that they have simply public fountains with fresh drinking water that are widely accessible throughout urban areas. And that may be an intervention we could think about.
Thank you. Thank you, Doctor. All right, turning to our next speakers, we are again very fortunate to have with us Marie Donahue and Damian Weinberg. Marie is the National Director and a recovery advocate for the Association of Power of Recovery. And Marie is the proud mother of 4 sons, which qualifies her for lots of things right off the bat. And she comes to the Power of Recovery with personal family experience with addiction and recovery. She spent several years advocating, learning the ins and outs of substance use disorder, and has experience really doing what so many of us know is hard, just navigating the best courses of treatment. Marie's from the North Shore. She works on building partnerships with organizations and assisting people to get to treatment. She really uses that professional and personal experience to get a caring approach to those who are looking either for their own treatment or for members of their family. And Damian Weinberg serves as the Director of Business Development and the co-founder at Power of Recovery. Damon is himself in long-term recovery and has worked in this field for over 13 years. And he, like Marie, uses both his personal and professional experience to create really caring environments. So many of us, I know on this Paul have been involved in that struggle and know how difficult it is, not only to figure out that help is needed, to get someone who wants help, to try to get help maybe for yourself, but then to find somebody who's invested in caring about it and helping you to do that. Drawing on his own family values, Damon's a proponent of a family style approach to recovery, including input and counseling for not only those on the path to recovery, but those in their family who've been affected along the way. So thank you both, Marie and Damon, for being here this morning. And we look forward to hearing about Power of Recovery.
Thank you for having us.
You want to start?
Yeah, sure. So yeah, thank you for having us. This morning, we're just here to really introduce ourselves. Like Marian said, I have personal experience with substance use through my son. So I have 4 sons. My oldest son is in recovery. I spent many years trying to help navigate the system with him when he was under 18. And now that he's over 18, and luckily he's been in recovery for 15 months now. But just my getting into this field was really just to give back. So to give back to other families, to give back to other people like my son. And we are here, Power of Recovery. We're an outpatient facility in Revere, Massachusetts. But what Damon and I really do is we work with individuals, we work with employers through an employee assistance program, just to help people get into treatment, whether it's in our facility or somewhere else. We start from detox and bring them to the, very end of recovery and continue recovery. And then I'll let Damon take it from here.
Yeah, absolutely. Thank you very much for having us today. Thank you, Marie, for giving a little background. Basically, like she said, it's Power, to just give you guys an idea of what Power of Recovery is, as we are an outpatient facility. It is with multiple levels of care, from partial hospitalization, which is commonly referred to as PHP, down to intensive outpatient, IOP, and then just regular outpatient or relapse prevention. We work in conjunction with sober living. We also own some sober living separately and independently from Power, but we're able to kind of be a one-stop shop for people that are looking to get into recovery. And for us, we're like a lot of facilities, we accept all the commercial health insurance plans, but unlike a lot of the facilities that we deal with that are in our network, we also take mass health, which is something that we've wanted to do. We got our start in the sober living business originally, and so our community, our population, the people that we run into more often than not, don't always have like a nice job with a commercial insurance plan. A lot of the members and people that we deal with are on some form of mass health. And so it was our goal from when we opened our doors 2 years ago, to take whatever steps and time necessary in order to get in network with mass health providers. And so we're very fortunate at this point in time, we can say that that's what we've done. Our program is pretty similar to most programs. There's groups and guidelines that you have to follow for BSAS in order to operate and to have certain types of groups we're in. I think the difference maker for us is who we are as people and who our team is that we put together. It's again, as Marian was kind enough to share, we have a very family-centered focus, and we work on the whole addict and alcoholic. And our goal is to just treat them and the family members that are impacted by the disease along the way, and to help them, move further along and just start their journey. We like to be a beginning step for them. And a lot of our practices are just client-centered, client-based practices that also involve the family. We usually give a little bit of time in the beginning for the client to come in, and we get to know them a little bit first, help develop a treatment plan, and then 2 to 3 weeks down the road, we start to investigate whether there's some family that they would like to have involved, and more often than not there is. So that's us. I mean, that's us in a nutshell. The sober living portion of us, we're known as Chelsea's House for that. We've been around for a much longer period of time in that side of things, probably about 11 or 12 years at this point. And Power of Recovery is something that we started and we opened in May of 2021, and we've been very, very fortunate to work off of a lot of the community partnerships that we built with Chelsea's House to grow Power and be able to serve our population. And we'd like to continue to do that and just be, you know, a resource for you guys. For us, anybody that reaches out to us from here or just in general, it really doesn't make any difference to us what insurance they have, regardless of whether or not we can treat them or we can help them. We're going to make every effort to make sure that they're taken care of at one of our facilities or another partner that we know and trust. Whether it's any Mass Health policy, Medicare, Medicaid, all the way up to, you know, your best Blue Cross Blue Shield they have out there, we'll make sure they're taken care of. So, and you know, like she mentioned, I have lived experience. That's my my process. We have a multidisciplinary team over here that matched it. There's a group of people, some with lived experience, some of their lived experience. We also have family members and people that have been impacted by the disease of addiction and alcoholism through their loved ones. So we feel pretty good about what we bring to the table and being able to cover kind of anybody that comes in, you know, what their situation is. One of us or someone that works here has, you know, some experience they can usually identify with to help build rapport with the clients and, you know, to continue to help them on their journey of recovery. I think that pretty much covers a lot of what we have to offer. We're definitely open to questions about anything we can do or questions about specific services as well.
Thank you both so much. I think, as so many people on this call know, it's often equally hard for the families to try to, especially in that stage where someone is no longer legally a child, but yet still has parents who obviously are still parents. So questions, comments for Damon or Marie?
Yeah.
I just
Sorry.
wanted to confirm. Thanks, Damon. So I see your website and I see at the end it lists all the insurances that you take, which is, you know, heartening. And so someone would just call you or the intake center and see how they can access the services, and you do like an evaluation and status. Okay.
Yes, ma'am. Yeah, they can. So Marie and I can both leave our contact information. We would leave our cell phone numbers, which we have on us at all times. We understand sometimes the calls are coming in at midnight, but that's when the desire and it's there for someone to get the help. And we always want to strike while the iron's hot. I'm sure all of you are well aware that if you have someone who says, I'm ready, you jump on that as quickly as possible and move forward there. We also have the office phone number that we can leave for you guys as well. We do walk-ins. We do intakes off the street. But yeah, the first order of business is getting in contact with us, and then just us checking what you have for insurance to make sure if it's us that we can take you. We accept most forms of Mass Health. We are working on the rest of them. But in the interim, while we're still working on that in-network contract, if somebody wants to come to our place specifically, we can help them change their insurance to one of the ones that we take. Or if they're, you know, something like it's acute and it needs to be handled now and they don't have time to change, we have some referral partners in the community that we've been working with for some time, you know, like North Suffolk. They're amazing. We love working with them. We've been working with them together for a long time, especially at Chelsea's House. But yeah, very simple process to call and get started.
Thank you.
No problem.
So a question in the chat about people in addiction who might be using cocaine, where there really is no detox program available for that. What would your thought be about the first step for somebody there?
Sure, absolutely. Did you want me to go for that one? Yeah.
So typically, depending on their usage, probably I would recommend a CSS, which is just the step right after detox. So most detoxes have a detox period and then an opportunity for people to stay for a couple of weeks in the facility, in the detox facility, different area, which is called CSS, which is basically just a residential. So they're still allowed to be in that inpatient environment, getting group therapy, but without, the medical detox part.
Yeah, so that they would be stabilized in there, like Marie mentioned. It's for anyone who doesn't know, it's a clinical stabilization service where it's a short term, up to 28 days, but it allows them because there is no medical withdrawal for the cocaine, but there is a need for somebody to have some separation and be in a controlled environment with some medical staff in case there are some other issues that do pop up. We would certainly, our first order of business would be to try and refer them to a CSS.
Other questions, comments that people have? All right. Well, thank you both, and thank you for the information. Oh, wait a minute. A question about, do you help people sign up for Mass Health?
Absolutely. So when any client comes to us, so yes, the short answer for that is yes, but also if somebody comes in the building with us, they have a part of every level of care for us. They are assigned a clinician for a minimum of one-on-one therapy session per week. And they're also assigned a case manager, which will help them attack any resources. If they come in without the insurance, obviously our first order of business is to help them. And we can absolutely, it's a very simple process that can actually be done over the phone with the client sitting with us. And also any other resources, if they come in and they're looking for housing, they need food stamps, they have some court cases or some other DCF issues that they're dealing with, we certainly will help manage all those situations for our patients.
Well, thank you. Thank you both for sharing that information. The more resources you have, the better it can be when somebody's looking for a placement. So thank you both so very much.
Thank you for having us. We appreciate it.
I want to take, of course, I want to take a couple of minutes. Pam, do you want to say a little bit about last week? Pam, did we lose her? Oh, no? All right. Pam, one of the things that, oh, is Pam there?
She
Pam,
was
do you want to
muted.
talk about
Muted.
Emma's house?
Sorry, I was muted. Thank
Oh,
you.
okay.
Thank you, DA Ryan. Yes, last week, DA Ryan joined us to cut the ribbon and joined us for our grand opening of Emma's House. So for those of you who are unfamiliar with us, the Megan House Foundation has a residential treatment home for women 18 to 26. In 2017, we opened our first Success Home, which is our sober home. And last week we opened our second, called Emma's House. Emma's House was named after a former resident, and we have beds for 9 women, and they can live there up to 24 months. They can be working, volunteering, or going to school. We have a house director. We have an in-house manager that's on site 24 hours a day. We also offer supportive case management while they're living at Emma's House, while they're continuing to recover and gain their independence. So people can fill out an application online. We can take referrals. It's listed on our website. Anyone can give me a call at the office to discuss, further information about it. We do not have an age restriction on our Success Homes. Our treatment home is 18 to 26, but after treatment, we're open to, it's open to women who have been through treatment and are looking for supportive lifestyle in a safe environment.
And it is a beautiful, really very beautiful house.
Thank you.
Great
Thank you.
project. Bob, you have anything you want to share about the partnership with the Veterans Court?
Yeah, thanks. Thanks, Attorney Ryan. Yes, I would. Very excited about this, actually. The Bridge Club was lucky enough to get a grant under the Homeless Veterans Rehabilitation Program. We actually had applied for a subsidiary of that grant, which was the Incarcerated Veterans Reintegration Program. So what that funding allows us to do is take veterans who are currently incarcerated, soon to be incarcerated, or recently been released, up until so much as like a year. They are able to get benefits from this program. And what we'll do is we're able to find them housing and get them jobs. With a host of partners through the job part, obviously there's Mass Hire. We're working right now with Middlesex Community College, our existing Corey-friendly employers that we've been working with, and a whole host of vocational training through the Helmets to Hard Hats program, Boots to Business program, all kinds of veteran programs, CDL training through NETS, the ATR vocational training opportunities that are available. So there's a lot of things that are available to these veterans. Most interesting part was that District Attorney Ryan reached out upon hearing about us getting a grant and asked if we were interested in being involved with a veterans court. Quite frankly, I never knew one existed, and most people that I've asked don't know about it either, including veterans. But it's actually pretty cool. It's a great benefit to the veterans who are in the mainstream judiciary. And Marion, correct me if I'm wrong, because I don't know all the particulars, but my understanding is basically if there's a veteran in the mainstream judicial system, and there are preclusions, it can't be a sexual offender or violent crime, but they can apply to this veterans court. If they're accepted, they actually get pulled right out of the mainstream judiciary and they are tried in this veterans court. And my understanding is that the judge's determination is final. In the veterans court, again, my exposure has been I've been there a couple of times and to witness it, but the judge has them actually coming back like a clinical type thing, and he tracks them through clinicians, through reports. And one of the issues that seemed to be ongoing was because of the specificity of the Middlesex County Veterans Court. They're not located in every district courthouse. The only one in Middlesex County is in Framingham. So people that are scattered, veterans who are scattered throughout Middlesex County, really don't have a problem have a problem getting there. So that seemed to be an ongoing issue. So we are starting, I think a week from next Monday, a shuttle on Monday. This court is only held on Monday afternoons. It's the only day of the week, unless it's a holiday, they do it on Tuesday. But the shuttle is going to be running throughout Middlesex County, transporting veterans to that court and back. It's going to be leaving Lowell, being the easternmost point of Middlesex County, or one of them, and traveling down 495, Route 3, 128, Route 2, and the Pike, and bringing veterans to court on time. And then the driver will be there at the end of the court sessions and drive them all home or back to the pre-existing. There's been specific points of pickup. Obviously, we can't do a door-to-door service, but they're centrally located along those routes, as I said. And that's going to be starting within a couple of weeks. So anybody that's at the sound of my voice right now that has veterans that need services, our service area includes Middlesex County, Essex County, Hillsborough County, and Rockingham County in New Hampshire. Any veterans that you know of that need those services, they have to have incarceration in their history, but we have the money and we need to spend it. So please reach out and we'll see if we can help these people. So that's all I got. Thanks, Marion.
Thank you, Bob. Anybody have anything else they want to share of programs, events? No? All right. I want to thank everybody for being here this morning. Again, I remind you, I have lots of Narcan, lots of fentanyl strips, lots of xylazine strips. I am happy to get them to you. So please just reach out to you and we will get them to you as fast as we can. And as you go about this work, and again, anytime we have someone lose their life, it's a tragedy. But keep in mind, it is our work that has driven that number down 20% since last year, just in this past month. So those are people that we are sparing from that tragedy. So I am grateful to all of you for the dedication and for the work. Thank you. Thank you so much. Oh, and for the people who want to know how to reach out to us for the xylazine, just respond to Madeline Gearin. You should have emails from Madeline. And if not, you can just email me and I'll get it to her. Thank you all. Take care. Be safe.
Thank you.